All right. Welcome, everyone, to today's session. We're excited for the last talk of this academic calendar. Laura, do you have the slides?
Steph, can you just stop sharing for a sec? I'll just bring up some intros.
Oh, sorry.
No, sorry, everybody. I don't have this part quite memorized yet. We just wanted to first acknowledge our support from an unrestricted educational grant from Mallinckrodt Pharmaceuticals, so thank you to them. And then as a reminder for our Canadian colleagues that this lecture series is a self-approved group activity as defined by the Royal College of Physicians and Surgeons of Canada, so don't forget to get your credit for that. So I would like to go ahead and introduce our lovely speaker today, Dr. Stephanie Boyd. We're so happy that she is joining us at 4 in the morning. We really appreciate you getting up early today. She's a staff specialist neonatologist at the Grace Center for Newborn Intensive Care at the Children's Hospital at Westmead and a clinical lecturer at the University of Sydney. Her research includes the effects of hemodynamic disturbances, including congenital diaphragmatic hernia and acute pulmonary hypertension, and their management on brain injury and short and long-term morbidity. Dr. Boyd is passionate about better understanding drivers of the cardiorespiratory illness in newborns and how hemodynamic problems and their intensive care treatments impact our important outcomes. So today we're very excited to have her give a lecture on vein of Galeno malformations and look forward to her talk. And then as a reminder, to please go ahead and put any questions that you have into the question and answer box, which we will have some time to answer at the conclusion of Dr. Boyd's talk. And then following that, we will be jumping over to a small group session for our junior fellows and our junior faculty and fellows, where we'll have a case presentation by one of Dr. Boyd's colleagues. So Dr. Boyd, you can go ahead and take it away and share your slides again.
Thank you. Thank you very much, Amy. It's a pleasure to be here, being able to talk with everyone. So just checking you can see my slides again. Great. Great, thank you. So thank you. I'm pleased to speak with you from Sydney. And this is a very interesting topic, I think, and we've all, or anyone who's been involved in caring for babies with these types of problems in the NICU knows how challenging they can be. So hopefully I will do justice to it. And my only disclosure is that I have had some AI help to turn some of my black and white tables into pretty pictures for you. So the objectives of this talk will be to review the pathophysiology and hemodynamic consequences of vein of Galeno and similar large EVMs, to look at the T&E and clinical features of high output cardiac failure associated with these lesions, and then to discuss some management strategies in the NICU. So vein of Galeno malformation, what are we talking about here? This is a condition that occurs approximately in every 1 in 25,000 births and develops during the 6th to the 11th weeks of embryonic life. It's an embryological anomaly involving the great vein of Galeno, which normally drains posteriorly into the straight sinus. In vein of Galeno, there are abnormalities characterized by arterial feeders entering the precursor of that vein. There are 2 subtypes, mural and choroidal, and the choroidal subtype is more common and is associated with more severe neonatal disease more frequently than is mural. And without treatment, this condition, mortality has been reported at more than 90%. So we've come a long way in how we manage babies with this condition, but it certainly requires a multidisciplinary and individualized approach. So in more detail, what can we see here? This is a T2 weighted MRI image of vein of Galeno. And then on the right, you can see a simplified kind of schematic diagram. So the vein of Galeno is marked 1 on the MRI, and then the dilated fetal vessels are 2. And then on the simplified graphic, you can see the falcine sinus marked 3, transverse sinus, and the internal jugular vein. So this is the anatomy that we're discussing here. Now, this was a relatively recent meta-analysis in the Journal of Maternal Fetal and Neonatal Medicine in 2022. And this is looking at outcomes for babies with vein of Galen malformations as reported in the literature. And you can see that there's still significant rates of mortality, neonatal and perinatal death. And also when we look at postnatal outcomes from a neonatal or surviving infancy point of view, really there were only 30% they're free from neurological compromise. So this is a condition with significant sequelae. So during fetal life, the low resistance placental circulation plays really a critical role in balancing the low resistance systemic shunt of the vein of Galen malformation. And this, I guess, competition from the placenta is a low resistance circuit is often considered protective, and it typically prevents the fetus from developing at least overt congestive cardiac failure in utero, although on echocardiogram you can still notice some changes like right-sided enlargement and sometimes some tricuspid regurgitation. Then related to that, according to the reduced forward flow theory, and we hear this a lot when we're discussing congenital heart disease as well, because blood is preferentially shunted superiorly to the brain due to the vein of Galen malformation, blood flow to the aortic isthmus can be significantly reduced, which can compromise the growth of the isthmus, and this can lead to hyperplasia, and this can even be suspected as coarctation of the aorta on prenatal imaging. In addition, that high primary blood flow in utero, which might be 3 or 4 times higher than normal, can result in pulmonary vascular remodeling, which can complicate the transition to postnatal life and contribute to pulmonary hypertension in this condition. So in fetal life, we have a relatively balanced system between the vein of Galen shunt and the placental circulation, and there is adequate systemic perfusion to the fetus. And then following delivery, those systems become unbalanced. So you get loss of the placental circulation, and at the same time as the lungs become filled with air and pulmonary venous return to the left heart is established, a PVR falls over a period of time, and you get a massive left to right systemic shunt, and that can lead to cardiovascular collapse. Depending on the hemodynamic significance of the shunt, this doesn't always occur immediately after birth, and it can take a few days as this transition occurs for the baby to become fully symptomatic, although certainly in babies that are most severely affected, it can be relatively early. So takeaway being that there is a significant circulatory change at birth, and we hear this a lot in neonatology and hemodynamics. And in this condition, it's also true that the loss of placental support can result in significant hemodynamic instability. So in terms of the blood flow, this is a schematic diagram. It's not completely accurate in terms of remodeling of the heart related to vein of Galen. But essentially, you've got venous return from the IVC as normal, relatively normal, and then increased venous return via a dilated SVC. Then you get your right ventricular output and pulmonary arterial supply to the lungs. And then there's also a significant, generally, and that it can be a problem, which we discuss if this isn't present, but you get significant right to left ductal shunting. Then after you have venous return to the left heart, left ventricular output, you get this vacuum effect from the low resistance circuit of the vein of Galen, really dragging a whole lot of blood up into the brain or into the malformation, which results in less blood available in the post-ductal circulation and can lead to significant lower body hypoperfusion. And you also get flow reversal being dragged up into that as a vacuum into the vein of Galen, such that you get flow reversal in the transverse and the descending aorta, as well as RV dilation and septal bowing related to pulmonary hypertension. Now, there is this sort of pseudo-coarctation physiology that due to this significant arterial steal, blood's diverted away from the systemic circulation into this low resistance shunt, which does result in aortic underfilling, particularly during diastole, as that vascular vacuum kind of siphons all the blood from the systemic circulation. And you do often see retrograde flow in the arch towards the brain as an illustration of the extent of that diastolic steal. This can create a pseudo-coarctation physiology where the systemic circulation and particularly the lower body suffers from chronic hypoperfusion, which can be quite hemodynamically significant. So how do we guide care for babies with this problem using TNE? It can be helpful at a number of stages. One is pre-intervention assessment and stabilization. And as part of that, we need to think about the underlying hemodynamic phenotype, particularly as it relates to pulmonary hypertension, as that's very important for selecting appropriate therapy. We use it for monitoring during intervention and also for guiding the timing and extent of endovascular intervention, as the goals in the newborn period are really around achieving stability rather than completely ablating or eliminating the shunt. And then after intervention, and this is post every intervention as it's generally a staged procedure, we then assess the hemodynamic effects. And actually our neuroradiology colleagues rely on us quite a lot for feedback about the hemodynamics and clinical improvement in the baby. And certainly in our center, we've had neuroradiologists say, just tell me when you think the heart failure is under control and we'll stop. So it's really important to be able to provide that real-time feedback and also to guide what therapy we're using at the bedside. So in terms of some echocardiographic features, there are some red flags. There does tend to be this very robust prominent SVC flow, and you can see that in the diagrams there. And this is a really important feature to look out for. And clinically, it's possible to hear a bruit over the head. But when you see this image on an echocardiogram, always be suspicious that there might be a large AVM involving the brain or in the brain. Then other features that we see, dilated head and neck vessels. You can see in image C there are significantly dilated head and neck vessels. And you also get reverse flow in the aorta, the proximal and distal descending arch. You can see D there is in the proximal descending and then E in the more distal descending aorta. And everything above the line there is reversed flow. And everything below the line would be the normal forward flow in the aorta. So you can see that's a significant disturbance of hemodynamics. This is a nice paper published in 2007 by Neil Patel. It's a small case series looking at hemodynamics in vein of Galeno. And what they found was that over 80% of cardiac output passed through the AVM, which would explain the significant reduction in lower body perfusion and severe lactic acidosis seen in some of these cases. And then the systemic perfusion was then further reduced by that diastolic steal through the AVM. Now, there are two diagrams here. The one on the left is of the normal heart, and you can see the ventricular outputs there around 250 mil per kilo per minute. SVC flow here was 86 mil per kilo per minute. And then if you look on the right, SVC flow in this infant with vein of Galeno was 807 mil per kilo per minute, which is enormous. And then the left ventricular output here significantly increased. And then what's really striking is that the blood flow up there to the upper body, or the sort of vacuum effect of the vein of Galeno malformation, meant that there was 734 mil per kilo per minute being dragged upwards and only 86 mil per kilo per minute moving forward through the descending aorta to supply the lower body. So this is a significant disruption to what should occur. And it's easy to see looking at that why you can see significant impairment in perfusion in this situation. Flow in the ductus here in these cases in two cases was up to 50% of right ventricular output. So significant ductal shunt, and was exclusively right to left, as often occurs in this condition. And some of that is protective in terms of maintaining lower body perfusion, and it also reflects the extent of pulmonary hypertension that can be observed. So some hallmarks on TNE for vein of Galeno. So on the apical four-chamber view, severe right-sided dilation with a dilated right ventricle and flattened interventricular septum, reflecting high right-sided pressure. And there are significant rates of suprasystemic pulmonary hypertension in this population. In the aortic arch, dilated head and neck vessels, as we've said, with retrograde red flow, demonstrating the steal phenomenon. Usual flow we see in blue away from the probe distally. In the descending aorta, we see flow reversal, as you can see diagrammatically there. And then, as we've discussed also in the SVC, we see a dilated SVC with significantly increased flow returning to the right atrium. Now, a greater proportion of retrograde aortic flow and suprasystemic pulmonary hypertension have been highly correlated with risk of mortality in one series of babies with vein of Galen. And in another series, the aortic steal percentage has been correlated with a number of outcomes, including multi-organ dysfunction, short-term NICU outcomes, cerebral interventional complications, and even later neurodevelopmental outcomes. Just a brief mention to consider when we're thinking about these lesions. I'm talking about vein of Galen as the archetype. There are other similar physiologies that we can observe, and one example is hepatic AVM. The physiology is very similar in terms of the lesion acting as a vascular vacuum and causing significant systemic steal. The IVC flow in this situation is the one that is very significantly increased as compared with the SVC flow, which makes sense if you think about the anatomical location of the lesion. We see dilated hepatic vessels, and the retrograde flow in the aorta tends to be more distal, again in keeping with the location of the lesion. But many of the effects from a cardiac point of view in terms of high output cardiac failure and pulmonary hypertension are actually quite similar. So back to what we were discussing in terms of vein of Galen, but also applicable in many cases to these large hepatic AVMs. We look at elevated right ventricular pressure. You can see on the right, the septal flattening. So the right ventricle right ventricular systolic pressure is increased, and you can see flattening of the septum there. And then you can see a prominent right ventricle there in the apical four-chamber view on the left. So when we talk about pulmonary hypertension phenotypes, and there's a lot of discussion about this in a number of conditions in neonatology, and what we've come to realize is that at the bedside, if you have a baby with significant hypoxemia and or hemodynamic instability related to pulmonary hypertension, even though they may look clinically similar, when you investigate in detail using TNE, you can see that there are actually a number of different pulmonary hypertension phenotypes, and they're not all the same, and they actually need different treatment modalities. So there is sometimes an assumption that all primary hypertension is due to raised pulmonary vascular resistance or a PVR problem, and that isn't the case. And certainly this condition is a good example of why we need to be really careful about making assumptions. So yes, you see a TR jet with a elevated TR jet, or you see a right ventricle under pressure. That doesn't necessarily tell you what the cause is, and we'll discuss this a bit further. So what do we mean by pulmonary hypertension phenotypes? So when we think about the contributors to right ventricular pressure, we think about flow times resistance plus, I guess, pulmonary capillary wedge pressure, but we use left atrial pressure as a proxy for that. What does this actually mean? So pressure, when we think of pressure, it's flow times resistance plus left atrial pressure. So pulmonary blood flow times PVR plus left atrial pressure. So in this situation, it is frequently the case that the pulmonary blood flow is significantly increased, and that is the main driver of elevated pulmonary arterial pressure. There are babies with vein of Galen malformation who do have elevated PVR due to, in utero vascular remodeling. And so it's very important to try and tease out the relative contribution of these to try and make sensible decisions about what to do in terms of hemodynamic management. So just to go into this a bit further, where there's resistance-mediated PH, pressure is predominantly due to an increase in resistance, i.e. PVR is the main driver. And in this situation, inhaled nitric oxide might be beneficial, although should be used judiciously due to the risk of conversion to a flow-driven phenotype or a contribution of flow-driven phenotype, and unless there's been severe remodeling. In flow-mediated pulmonary hypertension with high pulmonary blood flow, the increased pulmonary pressure is predominantly due to increased flow, and PVR may still be increased or may be relatively normal. And in this situation, nitric and other pulmonary vasodilators have the potential to be quite harmful. Really, that's twofold. One is reducing postductal perfusion due to the body's dependence on a right to left ductal shunt. And the other is pulmonary vasodilators you would expect to worsen any flow-driven pulmonary hypertension by worsening the left to right shunt. So using TNE, if we're thinking about flow-driven pulmonary hypertension, the goal is really around supporting systemic perfusion, and then we need to think about endovascular ways to better control the excessive flow. So in terms of ICU management, maintaining PDA patency, including that right to left shunt. And the ways we do that are around shunt modulation. And we do this also in babies with left to right shunts due to congenital cardiac disease, but thinking about minimizing excessive use of oxygen. So targeting saturations, around 88 to 92%, targeting a higher CO2, allowing permissive hypercapnia. And then from a cardiac support point of view, it's really important not to use anything with a strong vasopressor effect. If you increase your systemic vascular resistance, you will worsen any left to right shunt. And also, where there is significant cardiac dysfunction, increasing LV afterload further can be deleterious. So in terms of inotropes, we think about low dose epinephrine, up to 0.05 mic per kilo per minute. It's sort of a ballpark of what we think about as low dose. Sometimes we'd even start lower, 0.03. And then dobutamine is another option. And those are if there is cardiac dysfunction. In the setting of resistance-driven pulmonary hypertension, again, you can use inotropic support, but thinking about still maintaining the PDA to allow a pop-off for the RV under pressure, particularly if there's dysfunction. And then judicious PVR reduction and thinking about very cautious vasodilation due to the risk of conversion to this flow-driven physiology. So what does the initial NICU stabilization involve? Continuous monitoring, pre and post ductal saturations, ideally a right upper limb arterial line, continuous EEG if available, otherwise AEEG at the bedside, and at least cerebral plus minus somatic NIRS can be useful to think about cerebral oxygenation. Assessing markers of perfusion, regular lactates, they may need to be done even more frequently than that. Maintaining adequate hemoglobin for oxygen carrying capacity. We often think about this as well in left to right shunts. Following urine output closely, considering a catheter. And then from an imaging perspective, an early TNE or echo, and depending on what your center does, some centers will have an echo or a cardiology consultation from cardiology in the first instance to exclude congenital cardiac disease. Sometimes it's a team-based program. And then if you have a TNE program or a hemodynamics program, often that team will take the lead. And then particularly if there's signs of difficulties with oxygenation or perfusion, and then neuroimaging. At least you can do head ultrasound at the bedside, and then MRI really often requires some clinical stability. But the goals are to optimize oxygen delivery, monitor end organ perfusion, and really identify any instability early to help guide intervention. So in terms of a TNE guided approach, getting an early scan, and we do see those commonalities, the RV dilation, SVC dilation with high flow reversal in the arch, markers of pulmonary hypertension there, including bidirectional or right to left PDA, elevated TR jet or systolic eccentricity index of more than 1.3. But then beyond that, what is the predominant phenotype? And one clue is flow. In resistance-mediated pulmonary hypertension, usually the ventricular outputs are low, less than 150, as is the pulmonary venous blood flow. And you would expect to see elevated PVR index with a right to left, or at least, right to left ductal shunt. And then flow mediated, always be suspicious that it's not resistance mediated pulmonary hypertension if you see high flows. And in this condition, we often see more than 300 ml per kilo per minute with increased pulmonary venous blood flow and normal or relatively minor increases in PVRI. So if you have resistance mediated pulmonary hypertension, it's reasonable to consider a trial of nitric. But if you have flow-mediated, nitric really isn't recommended. And we're thinking about, as we discussed, shunt limitation strategies. And if you've got full-blown pseudocoarctation physiology with very impaired postductal perfusion, sometimes you even need to target lower saturations, 85 to 88% or similar. There is this third phenotype where pulmonary hypertension is less prominent, and it's more RV dysfunction that you see with a CAPC of less than 8 millimeters. Tricuspid annular plane systolic excursion is a measure of RV function, and RV fractional area change is another measure of RV function, those being low. So if the PDA is unrestricted and right to left, the RV has some means of decompressing from that high load, and you can support with dobutamine or low-dose epinephrine. If the PDA is restrictive in the setting of significant RV dysfunction, that's when you might consider, with a right to left shunt in this condition, prostaglandin to try and maintain ductal patency, as well as dobutamine, or in this situation, low-dose epi would also be appropriate. Just beyond the heart, what are the systemic consequences of this? So myocardial ischemia due to increased myocardial demand and reduced coronary perfusion pressure from the diastolic steal. Kidney injury with diastolic flow reversal and upregulation of the renin-angiotensin system. And anuria, it has been associated with poor outcome. And then bowel and mesenteric ischemia related to gut malperfusion. And post-intervention hypertension, so after embolization, restored perfusion can unmask systemic hypertension due to the upregulated renin-angiotensin system, which can impact cardiac function. And we also see a sudden increase in SVR after embolization, which can lead to LV systolic dysfunction and post-capillary PH. So really highlighting the need for serial monitoring, and a treatment option in that situation that has been used is IV milrinone. This Becerra score has been reported to try and quantify the degree of effect on various organ systems of vein of Galen malformation, and looking at cardiac, cerebral, respiratory, hepatic, and renal function. And a score of less than 8 was associated, or has been associated, with a worse prognosis. So what do we do? It's really a multidisciplinary approach. How do we care for these babies? Thinking about our interventional neuroradiologists, nurses in North America, respiratory therapists. In Australia, it's nursing and medical that look after the respiratory side of things. The family, it's really counseling from in utero and then throughout the process. And, the endovascular intervention extends beyond the newborn period, generally speaking. And so they've got this ongoing relationship with the neurovascular, like the interventional neuroradiologists, often neurologists. And it really is a collaborative approach, looking at hemodynamics, looking at the brain and all the other things from a supportive care perspective that we do in the NICU for really unwell babies. And it's really important that a lot of the decision making is collaborative. So in terms of the endovascular treatment, it is a staged approach really to allow hemodynamic adaptation and monitor the changing hemodynamics and clinical response, as well as minimizing the risk of acute neurological complications. More often, the transarterial approach is preferred, although transvenous is also used. And decision-making around the timing of intervention is really dependent on the disease severity, the baby's clinical condition, the extent of the cardiac failure, and the response to each staged procedure. And obviously it's more urgent in babies requiring mechanical ventilation or with multi-organ dysfunction. In terms of complications, there was a retrospective study at the Kids in Toronto of 33 babies, and they did find that the major contributing factors to periprocedural neurological complications were excessive embolization of the venous outflow, which generally is avoided, treatment of more proximal fistulae before treating the distal fistulae, use of large microcatheters, and then presence of the normal deep venous drainage into the venous sac of the vein of Galen. It's a collaborative approach with the NICU team and the interventional radiologists, and the goal in the newborn period is clinical stability rather than, as we said, complete ablation of the lesion. Down the bottom right, you can see 2 images side by side. On the left is prior to injection of glue, and then on the right, you can see the significant reduction in flow following injection of glue as an interventional procedure. So just in terms of future directions, there are some fetal predictors that are associated with a worse postnatal prognosis, including a significantly enlarged cardiothoracic ratio, presence of fetal cardiac failure, measures of the varix volume, and the appearance of the pseudofetus, which are dilated branches of the middle cerebral artery. And you can see, just looking at the 2 images at the bottom there, there's a significant variation in the extent of disease that is identified prenatally. So is there anything we can do about that? There's ongoing research, but I know Darren Orbach's group at Boston Children's, they have measured the medial lateral diameter of the falcine sinus as a predictor of clinical outcomes. And as you can see on the right, at the top image mortality is in blue, and at the bottom you can see the probability of mortality significantly related to the diameter of the falcine sinus. And so they have been conducting targeted fetal intervention for babies with the larger end of the falcine sinus at the I think it's median of 36 weeks. And there was a significant relationship with preterm birth, but they have reported excellent outcomes for the babies undergoing fetal intervention. So this is hopefully a promising space to try and reduce the severity of disease in the neonatal period for these patients. So in summary, this is a condition associated with really significant morbidity and mortality, even with optimal intensive care and intervention. These babies have complex and dynamic physiology, which changes over time. There is a really important component of risk stratification because all babies will be different, and maintaining an individualized approach both to their ICU therapy and their intervention from a neurovascular point of view. Close monitoring, including serial T&E assessment and phenotyping, is really essential to make sure you're giving the right treatment to the right patient at the right time. And then this is really a condition where collaboration and multidisciplinary care is really essential to achieve the best possible outcomes for these patients. Thank you.
Thank you so much, Stephanie, for that wonderful talk. You made it seem so simple with something that is so very, very complex. As a reminder to our audience to please go ahead and put any questions for Dr. Boyd in the chat. We do have a couple to start. The first is, how do you go about balancing the pulmonary vasodilator effects of PGE with the need to maintain ductal patency, in particular those who were, trying to drive that shunt? Do you have a specific dosing strategy you guys use?
That's a good question. I mean, unfortunately, we have this debate with our cardiologists often. Unfortunately, with PGE, you can't, it's not easily titratable like having an inotrope infusion. It's not like if the duct is a little bit open, if you give 5, it'll be a little bit more, and 7, a bit more, or 10. In nanogram per kilo per minute we work. So it depends on the baby. I tend to, if it's already open, and you want to maintain it open, we would usually use a lower dose, like 5 or 10 nanogram per kilogram per minute. If it's really closing and you need to open it, you often at least transiently need to use a bigger dose, like 20 nanogram per kilogram per minute, very occasionally 50, which is what we would see in babies with postnatal coarctation. But most of the time, if they're in NICU, usually, and they're being monitored, the duct isn't completely closed. So you can hopefully get away with a lower dose and mitigate those, vasodilator effects. I don't know, Amy, if you have a comment about what you do in Iowa?
I think it's a very similar, and I think the biggest thing is sometimes even on the lowest possible dose, you can really see significant side effects, or you see that PDA just utterly massive. And so sometimes what we've also done is done almost like a pause in the PGE, where if it's feeling like we're getting too much of the pulmonary vasodilator effects, the duct's getting way too big, we're starting to have systemic steal from a PDA even, where, you hold the PGE at 6 o'clock in the morning and you reassess, 6 hours later to kind of see how you're doing during the day, because it can be really frustrating that one dose works for one baby and doesn't work for another. I'm certain we've all seen the duct that's closed on PGE before, and that's always disconcerting to us as well, but yeah. Another question that really points to what T&E can bring to us with differentiating these phenotypes is being able to get ventricular output data. What advice do you have to those colleagues where they don't have access to T&E, or it's still up and coming at their program, and really having to rely on cardiology echoes that don't necessarily give us that information?
That's a great question. And I think when I think about cardiology echo for babies without congenital heart disease, I think about it like I order or I request other radiological investigations. In our center, if we ask for an echo, a lot of the time we're asking for a cardiology review and it comes as a package. And it's important to recognize the expertise of our cardiology colleagues. What I find helpful is to be very explicit about the kind of functional information that I want. I don't want to know, is there pulmonary hypertension? Sometimes if I can, I will stand with them while they scan and I get a little bit of extra information. Otherwise, I tend to say, look, I really want to know, they won't give you ventricular outputs, I think, because they often have concerns about, reliability of some of those measurements from a cardiology space. But they will be able to tell you, is the SVC really dilated? If you're thinking about diagnosis, does it look like high output? Like, what is the VTI for the right ventricular output Doppler, and the pulmonary outflow? Is it small? What does the pulmonary venous return look like? You can ask for qualitative things. And also if you say to them, look, this is a baby with vein of Galen where we're really trying to work out whether, for example, pulmonary vasodilators might be appropriate. Can you help us get some idea about whether there's excessive pulmonary blood flow and whether the LV function is normal? And I think just directing them in terms of the specific questions that you have is more helpful than just asking for an echo, because you'll often just get high output cardiac failure, no congenital heart disease, for example, and you need more detail. So I think it's only as good as the questions that you ask your cardiology colleagues, or sometimes if you call them and have a conversation, because they're very knowledgeable. And I think sometimes they don't necessarily know what information we want from an ICU point of view, and you need to be explicit about that. That's how we tend to get around it, or how I have managed it in centers without TNE. I don't know if, Amy, you have any other thoughts.
I think it's great advice of really treating it like, what is your exact question for them, and having that conversation. And we haven't had that experience, with inpatient, but for example, outpatient follow-ups that we're seeing, we're not getting, it's not a hemodynamics echo, but what we've been able to do is ask our cardiology colleagues just to take a couple extra pictures, just getting, a Doppler of the pulmonary valve. And what you can do is, just like you said, trend those VTIs even. You don't necessarily need to be able to calculate the exact output, but you can tell what VTI is more normal versus what's elevated. So I think that's a really great point. Not sure if your research kind of went into this in preparing for the talk. I certainly don't know the answer. I'd have to ask one of our neurointerventionalist. Do you have any idea if there's any recommended embolization technique or type of glue that can help prevent dislodgement or minimize the risk of serious complications?
I think I'll also have to defer to interventional neuroradiology on that. I do know that they do have a lot of conversations amongst themselves, and there are data in their literature or in neurointerventional literature around transarterial versus transvenous and the relative sort of risks of both. And I certainly have heard them discuss, the difficulties of making sure the glue is in the right place and having to withdraw the catheter quickly enough so it's not stuck to the glue. So there are a lot of technical procedural aspects, but that's probably a little bit outside my scope personally. Yeah.
I think the thing that we can draw that back to is to how we decrease the risk of serious complications during this is even using TNE to help guide how many vessels they go after, to help tell the interventionalists like how many are too many, because we obviously don't want to go and embolize off all of these vessels and lead to an acute increase in afterload and have a dead LV when they come back from their interventional procedure. Any other questions for Dr. Boyd while you guys are thinking? One of my questions is, what do you think is the next big step in taking care of these vein of Galen patients? It seems like we've really gotten to the point of it's not just all resistance-mediated disease. Do you see any changes with potentially the fetal interventions?
Yeah, I think the fetal intervention is really exciting. You've probably also heard Darren Orbach talk, and it's quite inspiring. That he has some case studies around specific patients, and you look at their prenatal imaging, and basically that there are babies where they have quite a significant lesion, but if they catch them before they've had significant parenchymal injury, in either in utero or in an early neonatal period, they can have a really good outcome. And it would seem to me that once you get above a certain threshold, the risk of the fetal intervention seems to be less than the risk of doing nothing based on the data that they have. It's not RCT data, but this is not a common condition. So, and I think it's really promising, and I think there'll be more research into that space. They did look at timing and the risk of preterm birth, and that the risk of preterm birth is higher than with some fetal interventions that are done earlier in pregnancy. But often this condition is diagnosed in the third trimester, so there isn't really an option for earlier intervention anyway. And now they've seen preterm birth, doing it at the late preterm stage seems appropriate. So I'm really interested to hear what further work is being done from a fetal point of view, and hopefully we will see less babies who are really severely unwell.
Yes, yeah, I think it's a fantastic option, like you said, for those who are diagnosed early. We seem to be frequently getting the unknown until birth diagnosis recently. So jumping off another question, the attendee asked, can we use MCA Doppler patterns to assess the hemodynamic significance of the shunt? And kind of along those lines, maybe if it's not the MCA Doppler pattern, what about using things like cerebral NIRS to help kind of guide your management, especially in those places where they might not have the ability to get T&Es quite as frequently?
Yeah, I think they're good questions. I think the problem is going to be that, to my knowledge, there aren't a lot of data about how to interpret it in these babies. So you might longitudinally in one patient have some numbers that can give you an idea of trends in the individual baby, but what should it look like, the MCA Doppler, or what should the NIRS value be when you have this enormous AVM, and how does it reflect, any relationship with meaningful outcomes as well? I don't know the answer to that. And I think in general, we're still trying to find how to optimally use NIRS in the NICU. And, that it seems to be that a trend over time in an individual patient can be more helpful than, a specific number. So I think there's still more work to do to think about other proxy measures we might have in the NICU.
Yeah, agree. We've really started to just use it as a trend on our patients with vein of Galen to try to gain more information and see if there's anything that we can tease out with it. But it is 100%. You look at the recordings on one patient versus another, and they're completely different. And so I agree. I think it's an interesting concept that we just need more data on, as with lots of things. So, all right. In the interest of time, I think we will wrap up this portion of the lecture series today. As a reminder to everyone, thank you for attending, and please fill out the evaluation. It's in the chat there.
We're going to wait for everyone to log in.